to our next speaker, who we're so happy to have with us today, Dr. Jennifer Uyeda, who's an assistant professor of radiology at Harvard Medical School and a recipient of multiple teaching awards in radiology. And she is coming back this year with her Can't Miss Radiology Diagnoses. Dr. Uyeda, please take it over.
Great. Thank you so much. All right, so thank you all for being here on this early morning, and thank you very much to the session organizers for the kind invitation to return this year to talk about this topic that's very near and dear to my heart. So certainly in the next hour, I cannot teach you how to be a radiologist, but what I can do is teach you basic interpretation skills and also review some can't miss radiology diagnoses in hopes that you can take these skills and apply them to provide optimal patient care, particularly when there's no radiologist overnight, or there may be a delay in reads. I'm sure a lot of you are feeling the delay in reads. We're so very, very swamped. So I do not have any financial disclosures. And again, over the next about an hour, we'll go over basic chest radiograph interpretation skills. We'll look at some various tubes and lines that are both appropriately positioned and also inappropriately positioned. We'll look at on radiographs as well as CT, some can't miss radiology diagnoses that you may encounter as a hospitalist overnight. We'll look at some protocol considerations. We'll look at some pros and cons of both intravenous and oral contrast in the use of CT. And we'll also briefly look at renal failure patients and contrast allergy patients. So for the first part, and throughout the talk, I have some scattered teaching points and some audience response questions. We won't launch the audience response because it takes too long in my experience. And I'll just ask you to think about the questions in your mind. So chest radiographs, they are by far the most challenging diagnostic imaging modality, in my opinion. And so let's set up the clinical scenario. So you have a patient who's short of breath, and you have a very large differential diagnosis, and you say, you know what, let's get a chest radiograph because a radiologist can provide us with a diagnostic answer. And this is the report that you get back. There are opacities that could represent atelectasis, pleural effusion, or pulmonary edema. However, airspace disease or pneumonia cannot be excluded. And you sit there and you scratch your head and you say, radiologist, I've been waiting a very long time for this read, and these were my differential considerations before I ordered the chest radiograph. So your read is basically useless. So let me delve into reasons why and show you why chest radiographs are so difficult to interpret, but also there are imaging findings that can make the diagnostic diagnosis with a high degree of accuracy. So conventional radiographs. The challenge is that we are using 4 different densities on radiographs. We are looking at air, fat, soft tissue or water, and also bone or metal. So let's go over these. We have air. We can see the nicely aerated lung. Fat. We can clearly see the fat in the supraclavicular fossa. Tissue underneath the diaphragm. And we also have metal as evidenced by the port catheter and also by the cholecystectomy clips. And so we have only 4 densities, and we're playing simply on shadows and differences in the shadows. So here's a normal chest radiograph. You can't diagnose pathology unless you understand what the normal anatomy looks like. So the right heart border is formed by the right atrium. We all know that the right paratracheal stripe is formed by the superior vena cava, outlined by orange. The trachea is a midline structure. It's going to bifurcate at the level of the carina. The aortic knob and the descending thoracic aorta is highlighted by red. And finally, the left heart border is formed by the left ventricle. So after I closely scrutinize the cardiomediastinal silhouette and all of these structures, I will then look at the lung parenchyma and I will drag my eye back and forth across one hemithorax to make sure that there are no focal opacities or differences in density. And then I'll do the same thing on the other hemithorax and look at the lungs. And then I'll take a step back and I'll look at both lungs, and I'll literally just drag my eye across both hemithoraces to see if there are any asymmetric densities. I also look at the intercostal spaces to make sure that they're symmetric bilaterally. And finally, the bones, and then underneath the diaphragm. So that's my typical search pattern. It doesn't matter what your search pattern is as long as you have a systematic approach. All right, so there are overlapping imaging features on chest radiograph, which can make them so challenging. We are also playing again on those 4 densities and also superimposed shadows. There are, however, imaging findings on chest radiograph that can be diagnostic certainties. So let's take a look at this example. We have a frontal and a lateral chest radiograph. Again, if you look at the lung parenchyma and you drag your eye back and forth, what you'll notice is that there is a focal opacity in the left hemithorax. If you look at the lateral radiograph, we know we can localize it to the left upper lobe, and we can do that because we can see that it is superior to the major fissure. And this is in focal airspace opacity with air bronchograms, and this is diagnostic of a pneumonia, and in this case, it's a left upper lobe pneumonia. Here's another patient. We can see on the frontal and the lateral radiographs, this patient has a pleural effusion, and this is the so-called meniscus sign. There is an opacity in the right mid to lower hemithorax, but if you'll notice that there's a curvature, this so-called meniscus sign, it's diagnostic of fluid, and this patient has a moderate-sized right pleural effusion. I get this question a lot. How do you know it's atelectasis? So we can see that there are plate-like or linear opacities in both lung bases. And we can see that very nicely on both the frontal and the lateral radiographs. And these are more likely to be atelectasis rather than focal consolidations that we had seen on the previous example. So this patient not only has atelectasis, but also effusions, because we can see that there are meniscus signs bilaterally. Right, here is the same patient at two different time points. On the left side, the patient is symptomatic, has shortness of breath. Contrast that to when the patient is asymptomatic on the right. So what you'll notice when you're first looking at the radiograph, when the patient is short of breath, the cardiomediastinus silhouette is larger. So there's cardiomegaly when the patient is symptomatic. If we look very closely and magnify when the patient's symptomatic, we can see a meniscus sign, and contrast that to when the patient's asymptomatic. You can see the Costa-Frank angle is very, very sharp and clear. So we know that the patient has cardiomegaly, also has an effusion, but if you take a very close look at the lung parenchyma, you should not see any lung markings in the peripheral 1/3 of the lung. Whereas when the patient is symptomatic, we can see these so-called curly B lines, or these horizontally oriented lines that are in the peripheral 1/3 of the lung, and these are so-called curly B lines. And so this patient, putting all the imaging findings together, has pulmonary edema. Here's another diagnostic sign. Here is an opacity in the right lung apex. Here is this golden S. It looks like a reverse S sign. And this is actually retraction of the major fissure on the right side. And this is secondary to right upper lobe collapse. So we have the opacification or the collapsed lung, and it's pulling up the major fissure, resulting in this golden S sign. Here are two different patients who both have the same imaging finding. There is complete opacification or whiteout of the lung. This imaging feature can be either seen in atelectasis or effusion. And so let's take a look, and we can differentiate the two. Atelectasis is the loss of volume. It's going to be caused by collapsed lung, but also volume loss. So what we see is the whiteout, but we have ipsilateral shift of the trachea. So if you look at the trachea, see how it's deviated towards the side of the whiteout? And this is diagnostic of atelectasis. And contrast that to when the patient has a large effusion. So we have similar imaging findings of complete opacification, this time of the left hemithorax. But if you look at the trachea, there's actually deviation to the contralateral side. So there's mass effect resulting in shifting of the trachea. And in this particular patient, they were able to drain 1,200 cc's of serosanguinous fluid. All right, on this chest radiograph, we can see that there are multiple pulmonary nodules and masses. We can nicely see the CT correlate. And whenever there are multiple pulmonary metastases, should certainly come into the differential consideration. All right, so I've kind of explained why and how chest radiographs are very difficult to interpret, but I've also gone over a few examples of diagnostic certainties that we can tell on chest radiograph. All right, here's a patient who I believe had chest pain, but here's a frontal radiograph. I'd say a lot of us would call this completely normal. There are no focal consolidations, no effusions. The Costa-Frank angles are very sharp. There's no pneumothorax. And this is teaching point number 2. So CT has much better contrast discrimination and diagnostic ability compared to chest radiographs. So if it makes a clinical difference and changes patient management, if the patient is symptomatic and you have a high clinical suspicion, please get a CT. And what you'll notice in this left lower lobe is that patient either has aspiration or pneumonia, and that's evidenced by these so-called tree and bud opacities in the left lower lobe. And even in retrospect, you cannot see them on the chest radiograph. They're very inconspicuous. So I feel like radiologists throw this term around. What exactly are tree and bud opacities? So here's a diagram of these so-called tree and bud opacities. It's irregular or nodular branching patterns. It's thought to represent, it does represent dilated and impacted centrolobular bronchioles. And so if you can hallucinate with me that this is a tree branch and that there are buds on the end of them. And so here's the CT correlate. You can see these tree-like or branches of a tree. And on the end, you have these nodular buds. And I think it's a better depicted on this initial CT that I had shown. So you can only really see tree and bud opacities on CT. And what exactly causes the impacted bronchioles? Well, it could be any source of infection. It could be airway disease, allergic bronchopulmonary aspergillosis, or even aspiration. So pretty wide differential diagnosis. Another term that we really love to throw around is ground glass opacity. So what exactly is a ground glass opacity? Well, it's this imaging term that denotes an increased or hazy attenuation of the lung that doesn't obscure the underlying vessels. It's caused by replacement of the alveoli by either fluid, cells, as in the case of tumor, or fibrosis. And so here's a really nice example of multiple ground glass opacities in the right lung. And here's a diagram showing the differences between the tree and bud opacities. Remember, you're looking for branches with nodular buds at the end. And contrast that to ground glass opacities where you have increased attenuation of the lung parenchyma. All right, this brings me to teaching point number 3. So I'm going to draw on my friend Prince William to help me illustrate this. So Prince William and I have a lot of things in common. We obviously have our differences, but we are the oldest of 2 children. Our parents were married in the same year. Prince William and I were also born in the same year. And we also believe in this, that one view is no view. So let's see how this translates to imaging. So here's a frontal radiograph. I would call this negative 100 times over. If you look, however, at the lateral radiograph, you can very clearly see that there is an opacity in the left lower lobe, and this is the so-called spine sign. So what exactly is a spine sign? So as you march your eye, if you focus on the thoracic spine and you move your eye down along the thoracic spine, because you have less overlying structures and less anatomic overlap, as you go down, the lung parenchyma should become more and more lucent or dark. And so as you come down the vertebral bodies, it is becoming darker until you hit this focal opacity. And this, the increased density is called the spine sign, and it denotes in this case, a left lower lobe pneumonia. So just keep in mind that we really, as radiologists, like more than one view. It really helps our diagnostic certainty and also increases our diagnostic capability, as very nicely illustrated in this left lower lobe pneumonia case. All right, let's shift our focus towards tubes and lines. So these radiographs, when I was in training, always caused us to scratch our heads. There are so many tubes and lines. It's really a source of anxiety for first-year residents. There are tubes and lines both inside and outside the patient. So let's focus on a few of them. The endotracheal tube should terminate a midline structure in the trachea. It should be 4 to 5 centimeters above the carina. And so we can see the bifurcation here. It should be 4 to 5 centimeters above that. The second tube that I look for is the enteric tube. It should course along the expected location of the esophagus. The side port and the tip should be below the GE junction. We have EKG leads that are external to the patient, and the biggest key is that they don't follow any anatomic source, and they also are attached to the EKG lead pads on the patient. This particular patient has 2 apically directed chest tubes and also a Swan-Ganz catheter through a right internal jugular approach, and we can see that coursing along the SVC and then going out the right pulmonary artery. So we're not going to use audience response, but I want you to think about looking at this chest radiograph. What is the most concerning finding? Is it the location of the feeding tube? Is it the presence of pulmonary edema, a left pneumothorax, or a right lung pneumonia? I'll give you a second to take a look at this. There is a chest tube in place. And in fact, if you look at the tip, it's actually not midline. It's actually deviating towards the right. And this malpositioned tube is actually in the right mainstem bronchus. So ideally, you want this obviously to go through the esophagus and terminate below the diaphragm. Obviously, don't feed the patient, and the Doboff needs to be repositioned. And another question for you: what is the next best step for this patient? Should the patient undergo a small bowel oral contrast pathway? Should the patient be sent to the OR for an XLAP, a barium enema, thoracic surgery consultation, or a consultation with urology? And so here's the tube. It is coursing through the right mainstem bronchus, but pretty peripheral in the right lower lobe. And so this patient needs a consultation with thoracic surgery. Not only is this Doboff tube incorrectly located, it's pretty far distal into the right lower lobe bronchus. One, don't feed the patient. Two, thoracic surgery should be consulted because the distal position of this tube actually can cause perforation of the small bronchioles. And when you pull out the tube, it can actually cause a tension pneumothorax upon removal. So just keep that in mind. Here's another ICU player. We have a right IJ approach Swan-Ganz catheter, and this Swan-Ganz catheter is too far peripherally located. It's in the distal right pulmonary artery, so that just needs to be repositioned. Here's another patient who has bilateral pleural effusions. Again, the meniscus signed bilaterally. Thoracic surgery did place a chest tube on the right side, but the tube was not draining any fluid. And so they couldn't figure it out, and they decided to get a chest CT. And so if we look at this, this top left image is going from the lung bases all the way up to the lung apices and the bottom right. I'll turn your attention towards this catheter. It is located on the right side of the chest. It closely approximates the ribs. And as we go cephalad, it just remains very close to the ribs, but actually never traverses the pleural space. And this is an extra pleural course of the chest tube. Some of the feedback that I got about showing this case previously to other people is that, well, did you really need a chest CT to make the diagnosis? It's very hard to make the diagnosis because, again, we only have one view that this is an extra pleural location, but a CT is fine if you're really struggling to find out the location of this tube. Here's another patient with a right-sided right pleural effusion that required a chest tube. A chest tube was placed under ultrasound guidance by thoracic surgery. Here are the post-chest tube placement radiographs. So this tube also was not draining any fluid, and they decided to proceed with a chest CT. And so here are 3 coronal contrast-enhanced CTs and 1 axial. If we follow the course of this chest tube, it is located between the ribs, and it is in the body. It's coursing medial. But if we look at it, it's actually not in the pleural space. It's actually in the hepatic parenchyma. So this right chest tube coursed through the liver and through the middle hepatic vein and into the intrahepatic IVC. And you can see that the tip is actually located in the left hepatic vein. This patient did need to go to IR for removal of this catheter because it was in a venous structure. All right, let's now look at some can't miss radiology at diagnosis, both on radiograph and CT. So here is a chest radiograph. I would like to know, what is the most concerning finding on this chest radiograph? Is it the location of the port catheter? Is it a left pleural effusion, left pneumothorax, or a tension pneumothorax? I'll give you a few seconds to take a look at that. And so this is actually a tension pneumothorax on the left side. So we have a pneumothorax, and we'll go over some of the imaging findings of the pneumothorax, but attention morphology is denoted by ipsilateral increase in the intercostal spaces. So if you look at the any two posterior ribs, you can see that the distance between the two on the affected side is actually increased compared to the unaffected side. And that tells us that there's more air on the affected side. There's also contralateral shifts. So remember that tension morphology is a ball and valve effect. So anytime you take a deep breath, the air comes into the pleural space, but actually can't escape. And so the air just accumulates in that pleural space, resulting in mass effect. So we have the increase in intercostal spaces. We have shift of the mediastinum contralaterally because of the mass effect, and also depression of the diaphragm. So what are the imaging findings of a pneumothorax? Well, we have the visceral pleural line formed by the collapsed lung. Peripheral to the visceral pleural line, we have an absence of lung markings. This is a pretty dramatic case of a large pneumothorax. The lung is essentially collapsed. Certainly not all cases are that evident. They may be a little bit more subtle, as in this case. Remember that the scapular body is a vertical line along the medial margin of the scapula. So don't confuse that with a pneumothorax. But what you can see here is that there is the pleural line. We also have the scapular border, and this is a pneumothorax. One imaging pitfall, you may be inclined to call this a pneumothorax. You're like, oh, I remember that talk that Jen gave about pneumothoraces, and we can see clearly that there's a line here that's not in any anatomic location. So this must be the visceral pleural line. If you look really closely, however, I agree there is a line that might be confused for a visceral pleural line, but peripheral to that, you can actually see preserved lung markings. So what is this line? It's actually a skin fold. So the technologist, particularly with the portable radiographs, will roll a cassette underneath the patient. And this typically happens in our older population where the skin's more flaccid and can actually roll under the cassette, resulting in these skin folds and these lines that mimic pneumothoraces. So just be careful, cognizant of that. You should definitely see the visceral pleural line, but peripheral to that, make sure you see an absence of lung markings in cases of pneumothorax. All right, let's look under the diaphragm. In this case, the patient had a colonoscopy, and we can see it very clearly that there's a large amount of free subdiaphragmatic air. And so this line here, the thin line, corresponds to the diaphragm. This line here is actually the liver, and all of the lucency between those two lines is actually the free subdiaphragmatic air. Sometimes it can be less dramatic. Here's a slightly more subtle case, but I would say that most of us would still see this free subdiaphragmatic air. Remember, keep in mind that upright radiographs are helpful in identifying antidependent air. Sometimes you might need a chest radiograph, sometimes an abdominal radiograph, or sometimes both. Here's a slightly more subtle case. We can see a very small sliver of lucency under the diaphragm. And here's a corresponding CT. So if you have a very strong clinical suspicion for perforated bowel, you can certainly start with a radiograph, but I would have a very low threshold to move to a CT. CT can not only make the diagnosis of pneumoperitoneum, but can also show the site of perforation, which our surgical colleagues appreciate in a large majority of up to 85% of cases. One of the most common causes of free intra-abdominal air is a perforated peptic ulcer. So this is a patient, if you draw your attention towards the distal stomach or proximal duodenum, we can see that there is wall thickening. There is mucosal hyperenhancement, but along the superior margin, there's actually a focal defect with a lot of surrounding stranding. And here's an axial correlate to that, but this is a perforated peptic ulcer. There's a very small focus of free air under the diaphragm, as well as some ascites. So free intra-abdominal air, it is an abdominal emergency that requires surgical or percutaneous intervention. Some contained perforations can certainly be managed conservatively. Most common sources of free intra-abdominal air include perforated diverticulitis, perforated peptic ulcer, and other less common causes including perforated carcinomas and bowel ischemia. And certainly iatrogenic causes can also cause intraperitoneal air. So here's an example of free intra-abdominal air on a patient's abdominal radiograph who is actually supine. And here's the correlate of the same patient with an upright radiograph. And so, yes, upright chest radiographs has more diagnostic certainty and diagnostic accuracy for free subdiaphragmatic air, but we can still make the diagnosis on supine radiographs. And this is the so-called Wriggler sign. We have air on both sides of the wall, intraluminally and extraluminal air, and that allows us to look, have a nice depiction of the bowel wall. And we can only see the bowel wall if there's air on both sides of the bowel wall, so intraluminal and peritoneal. And contrast that to this patient who has a very large dilated loop of bowel that's air-filled, but no free air in the peritoneal space. All right, small bowel obstructions. We can certainly start and make the diagnosis on an abdominal radiograph. We're looking for dilated loops of small bowel, and I use the criteria of 3 centimeters or larger as my diagnostic criteria. There may be air fluid levels on an upright radiograph. A really good question is, how can you accurately differentiate small from large bowel? On radiographs, small bowel have these valvulae conjuventus. So if you look really closely and you look at one side of the bowel wall, and if there's a line that goes all the way across to the other side of the bowel wall, those are the so-called valvulae conjuventus, and that's diagnostic of small bowel. In contrast that to colon that has haustra, and the folds are much thicker and wider, and the lines don't go all the way across. So we know that this is a loop of small bowel. If I measured it, it's more than 3 centimeters in size, and this is a case of small bowel obstruction. Most small bowel obstructions, you can make the diagnosis on radiograph, but they do go on to CT. Similar size criteria of 3 centimeters. I have made the diagnosis of a small bowel obstruction when the small bowel loops are less than 3 centimeters, but the key is to find dilated loops of small bowel. Oftentimes these patients will go on to CT, not only to make the diagnosis, but also to look for the underlying etiology. As we all are very familiar, many different etiologies can cause small bowel obstructions. But our surgical colleagues like to know if there are associated complications of small bowel obstructions. So at Brigham and a lot of large academic institutions across the country have adopted the adhesive SBO pathway, and it's a trial of conservative management in these patients who have a small bowel obstruction. And the theory is that a large proportion, up to 80% of these patients, will actually resolve conservatively without the need for surgery. And what it entails is dropping an NG tube, giving through the NG tube iodinated oral contrast, and performing serial abdominal radiographs to watch the course and the speed through which the contrast can reach the colon. And the theory is that if the contrast reaches the colon within 24 hours, that the SBO will most likely resolve without the need for surgery with a high degree of sensitivity and specificity. And the current guidelines recommend that if the patient's SBO does not resolve by day 3 to 5, that they do undergo surgery. So it's prognostication as well as really determining the need for surgery. And there are certainly exclusion criteria for this pathway. All right, let's turn our attention north above the diaphragm. So saddle pulmonary embolism. Pulmonary emboli, we're looking for filling defects within the pulmonary artery. We can see in this particular patient that there's a quite extensive clot burden. There's tumor in the main pulmonary artery. It extends basically into every segmental pulmonary artery there is. The more you look, the more you find. So we're looking to make the diagnosis, but we're also looking for the presence of right heart strain. This is done by measuring the diameter of the right ventricle to the left ventricle. The left ventricle should be greater than the right ventricle, but in cases of right heart strain, the right ventricle is larger than the left. Here's a patient with back pain, and I've given you some axial contrast enhanced CT images and a corresponding coronal. And we can see that there is a very large dissection flap. It involves both the ascending as well as the descending thoracic aorta. It does extend distally into the distal abdominal aorta and even into the common iliac artery. So remember, way back in med school, we're all familiar with a type A and a type B dissection. The difference is that type A usually need to go on to surgery. They do have extension of the dissection flap into the proximal or the ascending thoracic aorta. And the concern is that they can propagate into the origins of the coronary arteries. Here's another patient with abdominal pain who has an abdominal aortic aneurysm, but this unfortunate aneurysm has actually ruptured. And so on imaging, we're looking for a break in the abdominal wall, the aortic wall, excuse me. On contrast-enhanced imaging, we're looking for the presence of active extravasation. But in this case, I know that it's ruptured because if you look at the surrounding soft tissue, it should be fat. So it should be dark around this attenuation. But there is actually a lot of blood and stranding around this ruptured abdominal aortic aneurysm. And you can see that all this gray stuff is rupture. We love prior imaging, but this is what it should look like. So here you can nicely take a pencil and outline the aortic wall. Outside of that wall of the aorta, we can see that the fat is pristine. There's no stranding, there's no fluid, there's no blood. And contrast that to the patient who did, at this point, the patient did rupture. All right, let's go even more north to look at the brain. We can see that, So this patient on the very left-hand side, on the non-contrast CT, which is your best imaging modality to make the diagnosis of acute intracranial bleed because they are hyperdense. This blood posteriorly on the left side is interdigitating the sulci. So this is diagnostic of a subarachnoid hemorrhage. Here's another patient with a subdural hemorrhage on the right side. We can see that there is extraaxial hemorrhage that is hyperdense. It's crescentic in morphology. There's also some along the posterior and anterior falx. Anytime you see an intracranial head bleed, look for mass effect, look for midline shift, look for herniation. These patients should absolutely undergo a 4 to 6 hour repeat head CT and have a neurologic examination and a neurosurgery consultation. We do the short-term interval follow-up to make sure that there is no associated complication or increase in the amount of blood. As in this unfortunate case where in 4 to 6 hours, the patient's head bleed did significantly increase. You can see that the subdural hemorrhage is much larger. There is parenchymal extension as well as ventricular extension. Most importantly is that there's essentially effacement of the right lateral ventricle and enlargement and herniation. So this is crucial to get a repeat head CT. All right, let's now look at protocols and imaging considerations. So within our imaging toolbox, we have a lot of different imaging modalities. We have radiographs, ultrasound, CT, MR, and nuclear medicine studies that are available. So as an end user, as an ordering provider, it can be challenging to decide which imaging modality is the best one to start with and which one will answer your clinical question. So this is just a reminder that if you have any questions or have any diagnostic dilemmas, always feel free to pick up the phone and call the radiologist. We much prefer that over ordering the wrong study. It's much better for the patient to have a conversation between the two physicians to understand what the clinical question is and how we can best answer your question. So this is just I just wanted to show you. So when you order a CT abdomen and pelvis, this is just a drop-down menu in Epic. This is all the different ways that we can perform one CT abdomen and pelvis. And so my point in showing you this is not for you to accurately protocol studies. That's my job. But what I need from you as the ordering provider is to have an accurate and very detailed history and a clinical question, because this is all the different ways that I can protocol a CT abdomen and pelvis to best answer your clinical question. So the more information that's relevant that you can provide to us, the better that we can turn around that clinical question. And so here's a patient, I really love this example. So this is a patient who has a known pancreatic neuroendocrine tumor. And we know that these typically are avidly enhancing in the arterial phase. But without that history, we would just typically protocol it as a portal venous phase. So if I draw your attention to the liver on the portal venous phase, there are no metastases in this liver. But if you look at the arterial phase, there's a very large metastatic lesion in the right hepatic lobe that even in retrospect, you can't see on the portal venous phase. So yes, we would catch this. We would look at the patient's history, but any information that you can provide to us that's relevant, we can protocol the study much more accurately to make the diagnosis. All right, this question comes up a lot. While my patient has chest pain and I'm concerned about both PE and a CTA, let me explain why I strongly urge emergency medicine and hospitalists to put your money down on either a PE or a dissection. So this is how we actually perform CT pulmonary angiograms. This is a bolus tracking technique. So we give a little bit of a bolus of intravenous contrast. We then put a region of interest, the circle, around the descent or in the descending aorta, and we're going to periodically acquire images. And we're looking at the Hounsfield units or the density at this level in the descending thoracic aorta. And over time, as the contrast traverses or goes through the peripheral vein into the supravena cava, into the right heart, out, and then back into the heart, and then through the aorta, over time, as we acquire these images, the descending thoracic aorta is going to become more and more opacified with contrast. So it's going to become brighter, and the Hounsfield units are going to be brighter. And so we use this technique to optimally opacify arterial structures. And so when the CT machine says, okay, the Hounsfield units have reached my threshold at this level, then the whole machine triggers. And this allows us to have maximal opacification of the pulmonary arteries. So here is, so that's why it's crucial to tell us whether you're more concerned about an aortic pathology versus a pulmonary artery pathology, because the opacifications are slightly different, but it makes a diagnostic difference. So here's an example of a CT pulmonary angiogram. You can see that the pulmonary artery is much more opacified compared to the thoracic aorta. Yes, we can see both structures, but we like to optimally time our study to your clinical question. All right, so let's look at ordering some imaging. So this is a hypothetical patient, but probably not uncommonly seen in your practice. So this is an older woman who has multiple comorbidities, who presents with severe and acute abdominal pain. And the resident says, you know what, the abdominal pain might be out of proportion to the physical examination. So you sit there and you say, clearly this patient needs an imaging study. She has renal failure. She has severe acute abdominal pain. So should I start with an ultrasound? Should I get a CT? If I get a CT, should I do a non-contrast CT because she has renal failure? She also has diabetes. Or should I get a CT angiogram of the abdomen and pelvis because I'm concerned about mesenteric ischemia? Or should I just abort mission on the CT and just get an MR enterography? Because I heard that MRs are pretty diagnostically sensitive for pathology. Or should we just send the patient straight to IR for an angio? So now what? We have all of these various imaging modalities that are available. Do I order a study? Probably, most likely, but what should I actually order? So I really want to draw your attention to the ACR appropriateness criteria. Many of us are involved in the American College of Radiology, who came up with this evidence-based guidelines that were created to assist the referring physicians in making the most appropriate imaging or treatment decisions for a specific clinical condition. And using these guidelines helps providers enhance quality of care and contribute to the most efficacious use of radiology. So if you just Google ACR appropriateness criteria, this is what comes up. It's the first result. If you click on Browse Topics, it's broken down by body part. And in this particular case, we're worried about acute non-localized abdominal pain. So if you click on the narrative and rating table, this will come up. And you can see that there are multiple variants depending on the clinical presentation. But in this case, suspected acute mesenteric ischemia, this is the initial imaging. So this will tell you what is usually appropriate, may be appropriate, or usually not appropriate. And in this particular patient, in this clinical scenario, what's usually most appropriate is a CT angiogram of the abdomen and pelvis with intravenous contrast. So I really find that the ACR appropriateness criteria really is helpful in guiding your decision towards what imaging modality is next or is most appropriate. And it also gives you evidence-based guidelines to support that. All right, let's now look at the use of oral and IV contrast for CT. So this question comes up very, very commonly. Should I give all CT abdomen pelvic patients oral contrast? So we did a study back at BMC a few years ago now, looking at patients who present acutely in the emergency room with acute abdominal pain. And we gave all of these patients intravenous contrast, but no oral contrast. And we found that in patients who have a BMI greater than 25, that acquiring the CTs without oral contrast did not compromise clinical efficacy. And in fact, at Brigham, we haven't used oral contrast in the acute setting in at least 15 years. And we haven't had any diagnostic dilemmas. So patients, even including radiologists, will say, well, how am I going to make the diagnosis of small bowel obstruction or bowel pathologies if I don't have positive enteric contrast? You can certainly still make the diagnosis. So here's a patient, 2 coronal non-contrast studies. We can see that multiple loops of small bowel are dilated, and this is a patient with a small bowel obstruction. You don't need oral contrast to make the diagnosis. Here's an argument for not giving the positive enteric contrast. So this patient, I will tell you, has ischemic small bowel. If you look, this patient did get IV contrast, but no oral contrast. If you look at these loops of normal small bowel, you can see the mucosa that's nicely enhancing. However, looking at these loops that I've highlighted with the yellow arrows, these are actually ischemic loops of bowel. And if you look really closely, what you'll notice is that the mucosa is actually not enhancing at all. And we can make the diagnosis of ischemic small bowel and really nudge our surgical colleagues to take this patient to the OR just based on the absence of mucosal enhancement in these ischemic loops. You will not be able to evaluate for mucosal hyperenhancement or enhancement if you give enteric contrast, because it will obscure the mucosa and you will not be able to see enhancement or lack of. So that's one argument, very strong argument for not giving oral contrast. This patient did go on to the operating room, and you can see that there are frank ischemic loops of small bowel. So we do use oral contrast in certain patient populations. So if the patient is, as a rough guideline, post-operative within 30 days, we do typically give the oral contrast. If the patient has undergone penetrating trauma, you can give oral contrast. And if the surgeon specifically requests oral contrast, we will definitely give it. All right, let's look at IV contrast. So this is a young patient who had flank pain. And this was read as negative. There were no stones on this non-contrast CT abdomen and pelvis, no hydronephrosis, and no other finding to explain the patient's symptoms. However, because of persistent symptoms, the patient did go on to have a contrast-enhanced CT later that night. And what you can clearly see is that there's a large wedge-shaped area of hypoenhancement in the upper pole of the left kidney in this patient who has a renal infarct. There is no way that you can make the diagnosis without intravenous contrast. So if your patient does not have a history of stones, please give the IV contrast as long as there are no contraindications to IV contrast, which we will talk about in a few slides. Here's another patient whose status post-appendectomy who represented with right lower quadrant pain. You can see that there's some post-operative changes and some stranding both around the base of the cecum and also in the right lower quadrant in the abdominal wall. However, with administration of intravenous contrast, what really becomes clear is that there's an abscess at the appendectomy site adjacent to the cecum and also an abscess in the abdominal wall. And even looking back in the non-contrast is extremely difficult to make the diagnosis. Here's a patient with a soft tissue hematoma overlying the right gluteus muscles. It's not a diagnostic dilemma, certainly a hematoma. It's very sizable. However, when we gave the intravenous contrast, what we can see is that there is an extraluminal focus of hyperdensity, and this turned out to be a pseudoaneurysm in the soft tissue hematoma. And you cannot, absolutely 100% cannot see that without intravenous contrast. And this patient did go on to a coil embolization. Here's another patient with abdominal pain, red is negative, but because of persistent symptoms, what you can see is that there's actually an abdominal aortic dissection at the level of the renal arteries. Here's another patient with abdominal pain. Here's an SMA thrombus that you can very nicely see there's complete cutoff of the superior mesenteric artery with no opacification distally, and the patient does have infarcted loops of small bowel. Very briefly, so I had mentioned renal stones. We can very nicely see renal stones without contrast. We can see this sizable stone in the proximal left renal pelvis or ureter, and it is causing moderate hydronephrosis. And I think this is just left over from medical school days where the common teaching was if you're concerned about a renal stone, then get a non-contrast CT, because you might obscure the stones if you give IV contrast, but that's simply not true. If we perform, most of our studies are done in a routine portal venous phase, you can still see calcifications and stones very nicely on contrast enhanced CT. So if a patient does not have a history of stones and is presenting with flank pain, please give the intravenous contrast so that we can evaluate both the GU system as well as other organs in the abdomen and pelvis to look for the source of the patient's pain. But you can very clearly see that there's a small stone in the proximal right ureter. We can see the hydronephrosis and also the so-called delayed nephrogram, where there's delayed enhancement of the right renal parenchyma. This is just a few slides showing that with dual energy CT, which is a relatively new technology that we have, we can actually differentiate uric acid-based stones from calcium-based stones, which helps our urology colleagues appropriately treat uric acid stones. All right, let's look at renal failure and contrast allergy patients. So I know that there's some overlap between talks with this, but contrast-induced nephropathy. So the American College of Radiology, their position currently is that contrast-induced nephropathy is a real, albeit rare entity. The literature is flawed. It doesn't include a controlled group. Most of the studies have been done on cardiac angio patients, and they actually overestimate contrast-induced nephropathy. Most of us do use a threshold of a GFR of greater than or equal to 30. But the real issue that I want to highlight here is that contrast-induced nephropathy is an entity, although it is rare. If the patient does need contrast, intravenous contrast, we can certainly give the contrast, but a discussion needs to be had that the benefits outweigh the cons for the patient. All right, here are just some risk factors that warrant renal function assessment. So not every patient needs a GFR, but here are some risk factors that may warrant checking a GFR, and I've just listed them here for you. And these are taken directly from the ACR Clinical Resources Contrast Manual. A few words on dialysis patients. Patients who are anuric with end-stage renal disease who do not have functioning transplant can receive intravenous contrast. There is a theoretical risk of converting oliguric patients on dialysis to anuric status, but there is speculation on this. The contrast that we currently use, IV contrast, is cleared by dialysis. There's no need for urgent dialysis after contrast. The patient can continue on their normal scheduled dialysis schedule. Very briefly on allergic reactions, there are two different protocols that live out there. Most commonly, most of us use the 13-hour prep. And this is listed here, but it includes prednisone 13, 7, and 1 hour before the intravenous contrast. And then 1 hour before, in addition to the prednisone, Benadryl also needs to be administered. This can be very nicely timed with our CT technologists. Just give them a phone call and tell them that I have a patient with a contrast allergy. I will be administering the allergic reaction preparation, and they'll time out the CT with you. There are currently no guidelines on multiple contrast injections within a certain time period. We just ask that you have a discussion and make sure that the benefits outweigh the risks of injecting multiple times within a short period of time. Also consider hydration in patients who have a borderline GFR. It is important to note that pre-medication does not prevent all reactions. So if a patient has an anaphylactic or a very severe reaction to contrast, the pre-medication will not help. So just keep that in mind. All right, so we have gone over some basic chest radiograph interpretation skills, both normal and abnormal. We've gone over locating various tubes and lines, both appropriately and inappropriately positioned. We have gone over some can't miss radiology diagnoses that I hope were helpful to you, both on plain film and CT. We've talked about some imaging protocols and considerations, and also looked at the pros and cons of both IV and enteric contrast in CT. Very briefly, and there is overlap among other talks in renal failure and contrast allergy patients. So with that, I thank you very much for your attention. You have access to my slides. We do have time for questions, and my email address is listed here. So please have a low threshold to email me with questions, comments, or complaints. Thank you very much.
Awesome. Dr. Uyeda, thank you so much. We do have a few audience questions for you in follow-up to some of the content. One of the questions, so there's a few questions about detecting different things like pneumothoraces, et cetera, on chest x-rays. And I think the best way to start is a question that's been very upvoted, which is kind of how do you think about ordering a PA and a lateral film versus just ordering a PA film or an AP film when you're ordering a chest x-ray?
So I will say one view is not it's sufficient for patients who cannot get two views, but it really is helpful to have that second view. So if you can, and if the patient can tolerate a PA and lateral, always get the PA and lateral.
Okay. There's a couple questions about kind of picking up small apical pneumothoraces when reviewing scans on our own. And do you have any tips on kind of how to do that before we maybe get the read from the radiologist?
Yeah, so pneumothoraces can be tricky. There's a lot of structures in the lung apices that can overlap and mimic pneumothoraces and can also make you miss them. The good thing is if they're small, they're probably insignificant clinically. But I would say that symmetry is your friend. So look at the right, look at the left. If there's any asymmetry between the two, have a low threshold to move on to a different study or to get a repeat chest radiograph after a short period of time. But it is challenging. There's like the clavicles up there. There's a lot of soft tissue, a lot of vessels. It can be extremely tricky.
Yeah. The next question is tough, but I think we've all been in this situation where we have a patient for whom we're worried about the risk of giving IV contrast with like a reduced eGFR in the setting of chronic kidney disease, for example. So maybe somebody not on dialysis yet. Based on what you were talking about. But we suspect there might be a PE, and then we kind of get a not great quality VQ scan. And how do you kind of help counsel clinicians as they're making decisions on whether or not to scan with a pulmonary angiogram?
So in my personal opinion, VQ scan is a decent study for making the diagnosis. In the acute setting, it's just not a realistic study to perform. There's delay. You have to mobilize the nuclear medicine team. It takes a good 4 hours to get the study done. And so in total, we're talking at least 6 to 8 hours to get the diagnosis. If your patient is unstable and you need the answer before 8 hours, I would move on to a CT pulmonary angiogram. But at that point, it's really a benefit risk ratio. If your suspicion for a PE is extremely high and you can't wait 8 hours, move on to the CT, even in the setting of a borderline GFR. But it really kind of depends on your clinical risk.
Yeah, and to kind of continue down something that's a little bit controversial, and I think people have different opinions on, there are some questions about using like IV fluids or other preventatives for patients who are kind of in a risky GFR kind of level and then are getting IV contrast for a CT, and how you think about that.
So again, it's a risk-benefit ratio. If the patient has a borderline GFR, I think it's safe to give one dose of intravenous contrast and with a small dose of hydration with either before or after the IV contrast injection. But it really depends on your clinical suspicion. The amount of contrast, I will say that over the years has significantly decreased. So back when I was a resident, we would give these patients an angio like 200 cc's of contrast and not even really blink. But we've gotten the radiation, both the radiation as well as the contrast dose down so significant, we can actually do a very nice contrast enhanced study with only 50 cc's of contrast. So I think that that does help the patient, and also should be considered in your logic in determining whether the patient should get a CT.
Excellent. That was super helpful. And then I think our last question for you, you had given, you were talking a little bit about, not using PO contrast as much in the acute setting. Could you just reiterate a little bit for us? Like when as a radiologist, do you feel like we really need to use PO contrast? This would be super helpful for me.
Yeah. So there is a few scenarios where some people will make the argument that you need oral contrast. So some people say you need it in an SBO. You need it in the setting of perforation. How else am I going to see a perforation? So I would make the argument that you don't need it for almost all diagnoses in the abdomen and pelvis. So perforation, if you think about it, it's a very small hole in the bowel. The oral contrast is going to down the path of least resistance. It's going to keep going down the lumen as opposed to this tiny little hole. If there's a big perforation, we will see that even without oral contrast. So I would say that it's safe to say that if the patient's recent post-op, I would give oral contrast. If the surgeon is specifically requesting it, it's probably not going to be helpful, but we do give it in that clinical scenario. Okay.
Awesome. Well, Dr. Uyeda, thank you so much. This is always super helpful and it's empowering for us. We are going to take a break until our next talk at 12 o'clock. So we will see you then.